Maybe I can ask a question to Professor Dan. So you very nicely illustrate the lean NASH. And that in this population then in treating NASH, in weight reduction is there still a goal in this lean NASH population? And if it's not, then what other targets should we try to achieve?
Yeah, thanks, Matthew. I think when we looked at the BMI or weight as an indicator, we must remember it is a surrogate of the metabolic profile. And so therefore, in the lean NASH, what it means is that this indicator is not as good as what we hope to be, and we will need to find other indicators to help us measure the weight, the exercise as well as the diet change that's required. So as we heard just now, in Vincent's study, 3 to 5% of body weight will help you reduce NASH in more than 50% of the patients. But besides the weight, we also would have to look at, for example, waist circumference, look at all the other, even the waist-hip ratio and other parameters to see whether we are able to reverse the metabolic profiles. So exercise continue to be important. We don't want to send the wrong message that you are not overweight, you don't need to exercise. We need to convert your muscles, your fat into muscles, so the body composition need to change as well. BMI is just too approximate a score and may not give us adequate necessity. We are still trying to evaluate whether even body composition scan might do a better job in helping us assess the targets for this group of patients. Yeah, thanks.
No, thank you. Yeah, so I think similar result data also from Professor Kawaguchi's study that I think, yeah, he was not able to join for the QA now, but yes, by looking at his paper and personal interaction with him, it seems like from the exercise and that he looking at all these data that it seems like it doesn't reduce the weight, but however, it does improve the NASH, yeah, in substantial portion of patients.
Right. Yeah.
Yes. So yeah, Dean, can I ask you a question about about AI and machine learning? It seems that there's quite a few modality of AI and machine learning out there. Can you kind of comment on the advantage and disadvantages between all these modalities?
Okay, thank you. So I think, first of all, I kind of highlighted one point earlier about the need of using a second harmonic generation microscope, okay? Because one thing we use in common pathology is an ordinal system. Basically we do stage 1, 2, 3, 4. And the benefit of AI is really to provide, on top of that, you provide a fully quantification, right? Like 35%, 22%. So the idea of staining artifact is actually important, very important in quantification. When it comes to the identifying a portal track, then basically human eyes are now very good at, despite their staining artifact, people like you can see portal track and differentiate portal track from other structures easily. But to quantify to a 2%, 3%, then the staining artifact is important. Okay, so the other thing is to really use AI to understand the mechanism of action. So what we really, at this point, I think we don't just want AI to reproduce what people can do, to automate the process. I think that's especially in the phase where we are developing drugs, we're looking at drug evaluation, drug efficacy evaluation, combination therapies, etc. So we really need to use AI to help us ask and answer questions, to really find out where the MOA is, what kind of features are changing. So we really design our AI so that to give higher reproducibility as a tool to answer the MOA questions. So that, I think, is where we focus our AI technology development.
Thank you. Another question is, so you were showing that you subtract that zone 2 steatolic area and then compare the pre and post treatment fibrosis. Seems like the periportal fibrosis decrease improved. after the treatment. My question is that because as a metabolic NASH in adults, especially the fibrosis central or accentuated more in the beginning in the pericentral sinusoidal fibrotic area. So if say before you subtract that area, do you see the changes there, the collagens?
Yeah. So very, very good question. First of all, we understand that the central vein, around the central vein, right, is really a progression, like we see that in the natural history. Okay. As when it comes to regression, does it start also around central vein? This is something I have not seen the data of, and my gut feeling is it will not be the same for different drugs, for different targets. Okay. So my comment response to you is that we have done the analysis. We felt the tissue steatotic tissue area correction, and we did not see that trend. It's only after we did that correction we see that change, that trend.
I see. Thank you. So any question from the audience? So maybe my last question for Professor Dan is that, so do you see, is it prime time to set up the personalized medicine towards mitigating NASH?
Yeah, so I think there are multiple groups now, both from Europe, as well as US and Singapore, Asia, trying to come together to combine the cohort so that we have enough power to analyze the different subgroups, at least segmentation. So when we say personalized therapy, I guess the first step will really be just to segment this into the different subgroups of NAFLD disease, at least in terms of the metabolic profiling risk and the prognosis risk. And then once we have that clear understanding and data, we would be able to target the patients accordingly. I think the hope that at some point we are able to use a data-driven approach for individual patient, for example, based on his genomics, his gut permeability, his microbiome, that will take a longer time because the numbers will become very complicated. But at least the first step will be the segmentation into understanding who are the rapid progressors. I think that the omics data is coming very nicely together, and we should see some exciting results soon to help us guide the approach for different groups of patients. Thanks.
Thank you.